Hello, everyone. Glad we have sound. Let's just get into it. Let's make sure my PowerPoints are working properly. All right, this is part 2 of the psych medications. You don't necessarily, I guess, have to listen to these in order, but I think it would help. But this part 2 will be focusing on antidepressants, and I believe there's going to be a part 3 too, so please make sure you listen to all the parts for this presentation. Let's jump into it. Again, a little bit of definitions background. Please refer to the DSM-5 for the most current, accurate definitions and your ICM course. I will not be testing you guys over the most current definitions. I believe those will be covered in other courses. And for testing purposes, had students in the past asked me, I will be clear cut about the diagnosis. And so I don't want any ambiguity. That's what I get for trying to use a big word. I don't want it to be ambiguous. And I want to make sure that it's clear cut for you guys on your test questions. So hopefully you guys know that by now from me. And so with any case question or any exam question I have, it will be very clear cut that the person, for example, has depression, and then which of the following antidepressants would be used for this patient. So I don't really, like, the point of my exam isn't to really test you guys on the current diagnostic manual. The point for me is to make sure that you guys know the drugs and what they're used for and the categories and everything. So hopefully that goes well, and I hope you guys do well on the exam. But anyways, we will be talking about some different things. Reactive, endogenous, bipolar affective. Again, just read through, it's just FYI. And again, these may be slightly out of date because these are not necessarily what is in the DSM-5. Anxiety is also in the mix, and so some of these medications will help with the treatment of anxiety as well. And then just so you guys know, the current guidelines recommend that antidepressants are used with therapy in conjunction with that. But that's not something, again, you have to worry about for my exam. FDA warning, this is something that's going to be on my exam. Please worry about this. Please put a star here. There is a box warning on all antidepressants. We saw this in part 1 lecture, but all antidepressants increase the risk of suicidal thoughts, suicidal ideation, and action. So actually increased risk of suicide being committed by quote-unquote young adults. And so adolescents, children. So what does that mean? Your pediatric patients, and that means up to 24 years of age. So please note that is in the FDA warning. So younger people, I don't know how you want to think about this or what you want to remember, but basically, young children up to 24 years old that are being treated for depression and other psychiatric disorders. So this even is included. So for example, some of these antidepressants we're going to see, they can be used for anxiety. So it is still included, still something you need to be mindful of and thinking about with your patients, and definitely educate your patients. And then with your younger patients, I mean, maybe not your 23-year-olds, but definitely like with your teenage patients, definitely something that you need to educate their caregivers about. So most, again, just kind of making generalizations, I'm not speaking about specifics, but most 16-year-olds have, some kind of family member in their life that, need to be made aware of the increased risk of suicidal ideation, and the suicide risk is increased. And then here is just the specific language, just copy and pasted from the FDA. So for studying purposes, anything that has an FDA approval for depression, and like I've noted before, some of the antipsychotics have that FDA approval, you will need to attach this box warning to it and be mindful of it with your antidepressants. So hopefully that makes sense. Here are some categories of the antidepressants. There's some newer ones that we're going to talk about that are not on here, but typically on the top here, we have the older ones, the tricyclic antidepressants, and the monoamine oxidase inhibitors, a little bit older, and then the newer ones are here on the bottom. First off, tricyclic antidepressants, big laundry list here. Yes, please make sure you know them all. Some of these you will see being used for depression, and some you will see that are not used for depression. So we'll talk about that a little bit. But for studying purposes, please make sure you are looking at all of those. And like I said, you may see these in a variety of different settings, depending on where you end up practicing. One note with this, like I mentioned, it is an older class of antidepressants. These aren't used for depression as much as they once were. And the big reason is for adverse effects. So please note that. Not considered first line for depression, anxiety, and again, just really because of their tolerability. Patients do not like their adverse effects, and we'll get a little bit more into that specifics here in a second. Pharmacokinetics, not super important, don't necessarily memorize it, other than this last point here. The clinical improvement requires at least 2 to 3, and some sources say up to 4 weeks, so up to a month of use to start working. And spoiler alert, bad news is the adverse effects don't take a month. So people usually have adverse effects before it even starts to work. So within the first week of taking a tricyclic antidepressant, they start having these adverse effects they don't like, and then they may not have reduced symptoms of their depression, etc. So that is something to be thinking about. And again, another reason why people stop taking it, and reduce compliance, and why people don't like them. Mechanism of action, so please read through this, but they basically work with the neurotransmitters of serotonin and norepinephrine. And so just please go ahead and read through that. Uses, depression, we talked about. Some of the other uses and why, you might see them in some other settings. They can be used as an adjunct for chronic pain, specifically amitriptyline. Also, they may help with insomnia, amitriptyline as well. Enuresis, we have imipramine, and then OCD, obsessive compulsive disorder. So again, kind of depending on where you end up practicing, you may see these pop up. At pain clinics, for example, I've worked at a couple pain clinic pharmacies, helped out cover some vacation for some pharmacy friends. I would dispense this amitriptyline in conjunction with opioids or with some of these other pain medications we talked about in the MSK module, as an adjunct. So just be kind of mindful of that. If you are prescribing it, just let the patient know, because what happens is I dispense it in the pharmacy, and if I don't know, if it wasn't a pain clinic or I don't know the patient's a pain, suffers from chronic pain, I might say, oh, here's your antidepressant, or the literature, the printout that comes with the prescription will say, talk about it being depressant, and patients usually like, I'm not depressed, I'm in pain, but so yeah, just make sure you let the patient know why they are taking that. Adverse effects, so definitely put a star here. This is going to be the big reason why these medications are not tolerated, why people don't like them, and why they are not first line. So sedation's a big one, and this is because it actually involves the blockade of the H1 receptors. So you guys remember, hopefully with the antihistamines, first generation, they cause sedation. So that is an issue here, and it's sometimes can be desirable. So you notice back here, they can be used for insomnia. So sometimes the adverse effect that can be advantageous, and that may be something that you're looking for with your psychiatric patient. But definitely if someone's not wanting to be sedated, and then too, I mean, it can be pretty profound in some people where they have trouble driving or they have trouble staying awake during the day, etc. And so it can kind of interfere with their daily activities. The anticholinergic effects, again, put a star by that, highlight that. Dry mouth, xerostomia, and it's very bad xerostomia. It's very annoying. So full range of anticholinergic effects. Please go back to your old notes, and we've talked about anticholinergic adverse effects. Please make sure you are attaching that when you're studying these TCAs. They also have the phenothiazine-like effects, older antipsychotic, so you have to be concerned with orthostatic hypotension, and then with drug interactions and stuff. So if a person's on an alpha-1 blocker, that can be an issue there. Rarely you can have EPS, but that is not, fortunately, it's not super common, but that is one of those rare but serious ones. And then overdose. Unfortunately, when these were used for antidepressants, they were a popular pharmaceutical agent for intentional overdose, for a person who's trying to commit suicide. So I don't know what movies and TV shows you guys watch, but it's, kind of keep an ear out. I have come across, there's been a handful of movies and TV shows that I've come across after going to pharmacy school, because I didn't know about it before then, where the person's using these antidepressants to kill themselves, and it's typically a tricyclic antidepressant, because they are very, and I have to choose my wording here, they're very good at killing people, I guess, and that's a horrible way to say it, and definitely a horrible thought, but they're very, I guess they're they're very toxic, and so it's pretty easy to die of an overdose with these medications. And you think about it too, the patient population, it's these people have depression and maybe they already have suicidal ideation, suicidal behaviors, etc. And you're giving them something that's an effective tool to commit suicide. It's not, it's, by the way, it's a very unpleasant death. It's a very, painful overdose, uncomfortable death. But anyways, it can sometimes be reversed and corrected with sodium bicarb, and maybe some benzodiazepines to help with the convulsions. But unfortunately, it is something that, again, is very effective at killing people. So again, another big negative to this antidepressant. And then, like I said, that's why it's not really used as much. Newer agents, the SSRIs, so relatively speaking, compared to the tricyclic antidepressants, these are better tolerated. They have less adverse effects. And I'm using very careful language here. I'm being kind of a politician because as these have been out on the market longer and as people have been on them longer term, we're seeing that patients are having issues with the long-term use of these antidepressants, and so there are maybe some more issues now. So again, relative though to the tricyclic antidepressants, they are relatively speaking better tolerated, but still be mindful and still be thinking about adverse effects with these, and especially when they're on them long term. And the other big thing that's been coming out lately in the news, again, I don't know if you guys have seen this, or if you look for pharmacy related news like me, all the cool kids, no. But it has these SSRIs and have been out in the news lately because people have had withdrawal symptoms with them. So people are having problems with them and they are having withdrawal, which initially when they came out, they said, hey, no withdrawal. But for whatever reason now, I think because there's more people on them longer term, people aren't being discontinued off of them. So they're now recommending that a person is tapered off these drugs, which before that wasn't necessarily the recommendation, or rather it was something we were taught about in pharmacy school, but it was like, but it's not that big a deal. But so anyways, long story short, they're seeing that is becoming a bigger deal. So it'd be interesting to see what happens in the future. So definitely you guys stay tuned when you're out in practitioners, you guys have your fresh little nice shiny license out of PA school. Will there be worse adverse effects or will they be better tolerated? It's one of those things that I feel like is interesting with medicine. I don't know how you guys feel about it, but I think it's interesting with medicine where you have to kind of keep up and you'll see things in the news. And I think, let me check real quick. I'm going to see if I can find an article I saw recently. Okay, yeah, so here it is. This is an article my wife and I had read recently. So yeah, nothing, not sponsored by the New York Times or anything. It just happened to be an article. No political affiliate, whatever. I'm not trying to make any statement here with anything. But so you can find these types of articles on different websites or whatever. But anyways, many people taking antidepressants discover they cannot quit. This is from April 7th, 2018. So this was from, as of recording this was a couple weeks ago. I know you guys are going to be listening to this in the summer, but anyway, so yeah, this is just, I guess, a depressed lady with a cat. So 9 months to taper off Zoloft, for example. She had to drop off school. That's sad. I don't know if, anecdotal evidence, right? So I definitely encourage you guys to, if you are interested in learning more about this subject, I definitely encourage you guys to go to the Cochrane Library, go to PubMed, exercise your PICO skills, see if you can get, some evidence-based medicine to kind of see what it says. And, but anyways, but it's interesting in the sense that this article does highlight some things I talked about. A lot more people are on it. More people are on it longer term. And so because of that, we're kind of seeing people that are having maybe a little bit harder time getting off of it. So that is something to kind of be mindful of when you are prescribing these. Not only thinking about starting them, but then also think about taking them off. Because for better or for worse, primary care now has become like a kind of a big source of these prescriptions, as these SSRIs and these antidepressants and stuff. So it's something I'm assuming the majority of you all will come in contact with, inpatient, outpatient. You'll come in contact with these antidepressants on your rotations and then out in practice. Again, I would think the majority of you guys would. So anyways, just think about that. Try not to grandstand too much, but anyways, so yeah, sometimes I think things are interesting and they're out in the news and stuff, but anyways, not that New York Times article and stuff, it's not on the exam, and don't stress about reading that or doing, like I said, finding articles and stuff on it or anything. Mechanism of action. So this is one of those where it's nice that the category is the same as mechanism of action. Take home point, they are selective serotonin reuptake inhibitors. So they have an increased amount of serotonin. I've had students in the past ask me, why are we so concerned with serotonin? Well, the history of it, and Prozac was the first one, which is fluoxetine. It was just basically that was the one that we could manipulate and kind of isolate. And so that's why serotonin became the end-all be-all neurotransmitter. Now they've shown, so this was, I think in the 90s is when Prozac came out, but since then they've now shown that it's not just all about serotonin, even though that was initially thought to be kind of the end-all be-all when it comes to depression. It is one of the neurotransmitters that can be beneficial to manipulate, but it's, again, not the end-all be-all. But specifically for this class is the serotonin is what you are having to deal with. And then again, versus this TCAs, I've mentioned this before, they are better tolerated and not as bad of side effects. Here we go, SSRIs here listed here. I have the brand names there just because a lot of these, like I said, Prozac is kind of it's a household name. No, yeah, I feel like a lot of people have heard of Prozac at least, and that's fluoxetine. And these are all generic now, but you may still hear these being referred to by their brand name. For testing purposes, as usual, study the generic name only. Uses, so depression, makes sense, antidepressant. OCD, panic disorders. We also used OB-GYN for PMDD, bulimia, that may help with bulimia, and anorexia, not on here, but it can sometimes help with your anorexic patients. Adverse effects, again, usually well tolerated, but definitely some GI adverse effects, headache. The nervousness, like anxiety, can kind of make people feel a little bit worse. Like I mentioned too, the increased risk of suicide. So when you're adolescents or 24 and under patients, and then sexual dysfunction is one that a lot of patients will complain about, and so that is one that's a common one that you may hear complaints about, and why people will want to get off of it. Other antidepressants. So as far as categorization purposes go, stick to my categories. The only reason I'm mentioning that is there's been students in the past that have brought me other resources, so other textbooks, etc., and they have these labeled differently. And I'll give some different categorizations here in a little bit as well. But yeah, but anyways, this book just put them on under as other. So these are obviously different than the TCAs and SSRIs. Adverse effects, these are usually, again, relative to the TCAs, better tolerated. So hopefully you're kind of noticing a pattern here. You're kind of noticing that, I'm not going to say TCAs suck, but they're kind of, hopefully that now there's a reason, or rather you guys have reasons, and that's not medical, not medically professional to say that drug sucks, but so I know that, so sorry about that, but that it's not going to be preferred first line agent. So Amoxapine, this is actually technically a TCA, and it's in other because it's so much newer and the other ones are so much older. But again, technically speaking, you can classify it as a TCA. This one is unique for the TCAs because this one is the one that has been demonstrated to have antipsychotic activity. So as far as classification is concerned, had students in the past, so where do I put this? Do I put it under TCAs? Do I put it under other antidepressants? Do I put it under antipsychotics? The answer is all of the above. So yeah, sorry, that's annoying, and I'm purposely not trying to be annoying with you guys, but please think of this one as a TCA, because that's technically correct. Also think of it as an antidepressant and as another antidepressant, and it can, yeah, be an adjunct antipsychotic because of its antipsychotic activity. So where do you see it? Probably you will see it for your probably you see it for your patients who have psychosis and are kind of treatment resistant and having trouble, and again, kind of as an adjunct, probably not first line. Because it is a TCA, you will still be concerned with the adverse effects of this medication. Bupropion, the generic for WELLBUTRIN. This is an interesting one. It is atypical. And so again, that's another labeling that you will see in other textbooks, other sources. So that's also, that would be a correct label for this. Interesting, just kind of FYI, it is structurally similar to amphetamine. It specifically inhibits the dopamine reuptake. Uses, please make sure you study all of these and make sure you know all of these. It can be used for depression, smoking cessation, and ADHD. So the interesting thing about this one is this one actually has two brand names. So the generic is bupropion no matter what. WELLBUTRIN I guess because it makes you feel well, has an FDA approval for depression. And I'm just guessing on the name. I don't know. But anyways, the WELLBUTRIN, FDA approval for depression. Zyban, Z-Y-B-A-N. I think I'm spelling that right. That is for smoking cessation. So that is FDA approved to help you quit smoking. But again, that was a bigger deal when they were brand name, but now that they're both generic, it's, Bupropion, basically. So just an FYI on that. I've had students in the past ask me about, they've heard about Zyban or whatever, and they want to know what the difference was between Zyban and WELLBUTRIN. And really, it's a brand name FDA approval patent thing. It's not, it's the chemical, the Bupropion's the same. Adverse effects, usually well tolerated, again, relative to the TCAs. To be concerned with seizures. It can cause anorexia, which can sometimes be a benefit if you have an overweight patient, especially if they have an overweight patient who is on an antipsychotic that can cause weight gain, right? But related to that, you have to be careful with this because it can actually make the psychosis worse. So this is one of those like the art of medicine. You have to really be careful sometimes with some of these things you're prescribing because you can actually make things worse. Or, or definitely not, maybe if a person already has bulimia or anorexia, maybe this isn't a good choice because it can actually cause more anorexia. So anyway, just be thinking about that. And again, hopefully, I believe you'll be getting kind of a clearer picture of some of these disorders in your ICM course. Next up, we have Maprotiline. Generic brand name there. This is an SNRI, so this is selective norepinephrine reuptake inhibitor. So like the SSRIs, but this one specifically has an effect on norepinephrine. This is a T little e CA. Deca. No, that's not. No one says deca. I don't think. I say deca. No, so T little e CA. So this is a tetracyclic antidepressant. So similar to TCA, very as far as the organic chemistry is concerned. And I don't make you guys do symbols. I still have nightmares about organic chemistry and having to draw these, and we had to learn them all in pharmacy school and stuff. But so I purposely keep them out because I have PTSD. But so it's if I showed you the structure, they're very similar, and so similar as far as adverse effects as well, and interesting as far as it's kind of got a niche corner of the market there, but maybe not your first line. Mirtazapine. Generic for REMERON, another atypical agent. This one works on the serotonin receptors and the alpha-adrenergic receptors. This one can help treat depression. Again, this will be people who do not tolerate the SSRIs, so maybe second line to that. And then this also may be beneficial to patients who have anxiety. And then adverse effects, weight gain, and then sedation. And one note on the sedation is I have seen this being prescribed. And again, this is in the psych hospital, so this is with your psychiatrist, not your general practitioners. Use this for its adverse effects. So they will use this for sleep. So mirtazapine, QHS at bedtime, PRN, insomnia, and maybe like 15 milligrams, I think is the strength on that they would use. Interesting adverse effect there. And again, maybe advantageous depending on your patient. Trazodone. This is also known as a serotonin modulator. And you'll notice its mechanism of action involves serotonin and its modulation. It also has significant blocking of the histamine and alpha-1 adrenergic receptors. So we're going to see that implications with its adverse effects. Here's the mechanism of action again. This may cause this may cause cardiac arrhythmias and priapism. So that is something to note and something to be mindful of when prescribing this. Use is depression and then insomnia again because it's a very strong H1 blocker, causes sedation. So again, in the psych hospital, I've seen this Trazodone, I think 50 milligrams, QHS, PRN, insomnia for an example of a prescription. That is one that you may see being used because of its adverse effect. Vilazodone, another also known as VIIBRYD, serotonin modulator, related structurally to the Trazodone, involving again the serotonin receptors, use for MDD. Nefazodone, this one has less sedation than the Trazodone. Again, chemically, the structure is related. Mechanism of action, again, serotonin involvement there. Box warnings, though, this is very hepatotoxic. So in the US, we have a box warning for hepatotoxicity. In some countries in Europe have discontinued this use of this medication, so it's not available worldwide, depending on where you guys end up practicing. And it's because of the hepatotoxicity, so please note that. And because of that, I think I've maybe only dispensed it a couple times. I rarely see Nefazodone, because again, compared to the VIIBRYD and the Trazodone, these don't have the hepatotoxicity boxed warning. Now we have a newer one, the Vortioxetine TRINTELLIX. You may have seen the commercials or advertisements for that. And this one is a SSRI, or because it blocks the reuptake of serotonin, used for major depressive disorder. And it's, dual inhibitors. And the reason this is one separate is just because it is a newer one. But so for organization purposes, if you want to put it with those other SSRIs, you can. Dual inhibitors, also known as the SNRIs, so serotonin and norepinephrine reuptake inhibitors. We have the list here, brand names out here on the right. The newest ones are here. These two last ones are the newest ones. Mechanism of action is similar to the TCAs. However, they have much better adverse effects relative to the TCAs. They can be used for depression. And then duloxetine, which is Cymbalta, is actually interesting because it can also help with pain. So you will see your pain patients on it potentially. And then especially those pain patients who have depression and anxiety. Next up, we have the monoamine oxidase inhibitors, the MAOI medications. Let's see those. Here is the list here. You notice there's a couple that aren't in the textbook, but please make sure you are studying all of those here. And we have the brand names out to the right-hand side. Pharmacokinetics. These are very long-lasting. These also take a while to start working. Oh, by the way, too, on the note with those other antidepressants, so, with the majority of antidepressants, they can, SSRIs, SNRIs, etc., they can take 2 to 4 weeks to work as well. So that is an issue you can have with all these antidepressants. So mechanism of action, they inhibit monoamine oxidase A and B. So they increase the concentration of norepinephrine and serotonin. So the use on these, they have atypical depression and depressions and refractory, and that do not respond to TCAs. So these are like the TCAs in the sense that these are not considered first line. There's a lot of problems that we will talk about with adverse effects and drug interactions and food interactions. So please stay tuned for that. But adverse effects here, hypertensive crisis, and that can happen from eating certain foods even. And so that is definitely something. Hepatotoxicity, it's also something that can be very detrimental. And then CNS effects, restlessness, insomnia, and then hypotension. So because of the adverse effects, not something that, again, is first line. Also, you have to be concerned with drug interactions, so please put a note by that. And again, another reason why these are not first line, because you'll have to worry about the drug interactions. Here's some drugs that can have the drug interactions with the MAOI inhibitors, and specifically with the SSRIs, TCAs, they cause serotonin syndrome. And they have potentially very severe reactions that can be helped by treated by cyproheptadine, so please note that. But again, another reason why they are not first line. And then food interactions as well, which I didn't mention on there, but I believe it is here. Yeah, so it's foods that contain tyramines. This is like things like your aged cheese, red wines, all these delicious foods. I think, what were some of the other ones? But I forgot. I'm forgetting the list now of tyramine-containing foods. But it's a lot of delicious foods, basically. A lot of stuff I like to eat. I was like, aged cheese and red wine sounds delicious. But anyways, there's a lot of other good foods that have tyramine as well. And so with those foods, you can have a hypertensive crisis and have to be hospitalized. So another reason why these are not first line. As always, though, please read through this chart and make sure you look at the clinical applications, adverse effects, and contraindications. Another great chart here. This is from Up to Date. This is antidepressant doses for unipolar depression in adults. The reason I gave this chart is, not to stress you guys out about the dosaging. I just wanted this to be kind of an FYI, so you will be familiar when you are out on your rotations, you have an idea of what is usual starting dose, usual total dose per day, and then the extreme daily dose range. So the extreme daily dose range is usually what the psychiatrist will prescribe. I may call the if it's a general practitioner, or if it's like an endocrinologist, or if it's I don't know, general surgeon, and they're prescribing fluoxetine, and they're going up to like 300 milligrams, or wait, 80 milligrams fluoxetine, or fluvoxamine, I'm sorry, if they go up to 300 milligrams, I'm definitely going to give them a call. But if the psychiatrist is pushing the dose and going up there, I will not give them a call, because it's typical, or again, my experience with the psychiatrist in San Antonio and at Texas Tropical in the Valley, that the psychiatrist will prescribe these extreme daily dosages. So if you're working with a psychiatrist, definitely go up there and get extreme, get crazy. No, you know, you can go up to the extreme level, but with if your general practice, or if you're not a specialist, you know, stick to the lower, more conservative dosaging, and then, you know, refer your patient to your psychiatrist if you feel like they're going to need higher dosing. But yeah, for testing purposes, don't worry about memorizing the dosages. I just wanted to make you guys kind of aware of that there is, and this is true, the extreme dosing is true with antipsychotics as well. They'll have the manufacturing recommended dosing levels, and then like with Zyprexa or something in the psych hospital, it's like they were going 4 times the highest dose. And, you know, I would call sometimes, or sometimes have an issue, but for the most part, if it's a specialist, I would let them kind of do their thing, because they don't like me calling them and they get upset with me. No, but yeah, they're like, so anyways, no, they were nice psychiatrists. It's funny too, when I started working at the psych hospital, I was like, oh, I got to study all my psych drugs. I got to, like, you know, brush up, get all the newest ones, latest and greatest, and make sure I know all the dosage, whatever. And then, like, 9 times out of 10, the questions the psychiatrist would call me about, they're like, hey, yeah, what's the max dose of Benadryl or something? Or like, hey, what should I prescribe for this guy's cholesterol and his triglycerides? And then, you know, so it was all non-psych stuff. So the majority of the time in the psych hospital, I was answering questions about diabetes drugs, cholesterol drugs, allergy medications, cough and cold stuff. Like, hey, what's the strength of the Robitussin you guys have? And like, how do I prescribe? Like, what's the SIG? What should I do, a teaspoon or 2 for this adult? Or how much should I do of this coat? Whatever. And it was funny that, yeah, the psychiatrist had like no idea about like Robitussin dosing or something. But then anyways, so yeah, that's not on this essay there. Did I put it twice? Okay. This table though is, put a star by this. This is side effects of antidepressant medications. So this first, the dosages, FYI, for testing purposes, but for testing purposes for my exam, please put a star here. Side effects of antidepressant medications. I want you guys to make sure you know which ones have anticholinergic adverse effects. And you notice the tricyclics, right? No surprise there, are lighten up the board, so to speak. They have pretty high rankings. Drowsiness, insomnia, agitation, orthostatic hypotension, QT prolongation, so increased risk of arrhythmias, GI toxicity, so those GI adverse effects, weight gain, and then your sexual dysfunction. So please make sure you're noting those. You don't have to memorize necessarily that, oh, citalopram has +1 for weight gain, but definitely make generalizations like I highlighted here. Anticholinergic adverse effects, you're down here on this part of the chart, your tricyclics, tetracyclics, and your MAOIs, right? So are going to be lighting up the board there. Weight gain, let's go scan through it. You get your TCAs again for weight gain, a little bit with your SSRIs. So that may be something to be thinking about. Atypical agents, you know, have more insomnia, it looks like, maybe some of the other ones. So yeah, so this chart here, and the way to study for my exam with this chart is to make generalizations where you start noticing trends. You kind of start seeing when you're prescribing an SSRI, what adverse effects should you be thinking about? When you're prescribing a TCA, what adverse effects should you be thinking about? What are the most common adverse effects? And so on and so forth. Atypical agents, etc., SNRIs, etc. So all good stuff here. So with that is where I'm going to stop for this part 2, trying to break this up so it's not too bad for you guys. So as always, thank you guys for your time and attention. I appreciate it, because without you, there is no me. As always, please email me if you have any questions, comments, feedback, or anything else that you guys find interesting or related. Other than that, I'll talk to you guys later. See you in talk to you in part 3.